Next is my pleasure for Dr. Steve Wexner, I'm sure everybody knows, from the Cleveland Clinic, Florida.
Thanks again. Thanks again for the kind invitation. I'm happy to be here addressing you, and I knew how beautiful the video before mine would be, so I didn't include any video clips because there's no way that we can do a dissection that nice in this country. So my compliments again for beautiful lymphatic dissection done across the Pacific. What I'm going to do instead is just to review with you some of the data and some of the evidence that we are looking at very critically in this country rather than viewing a little bit of the techniques. And if we think about what's new in rectal cancer, there's a couple of things new beyond laparoscopy, and I just want to touch on a few of those things. Some we hear about a lot, like TME and lateral dissections and cylindrical APRs, and then there are a couple others that I want to touch on. If we first look at why we got where we did, we used to do a standard dissection and transect 5 centimeters distal to the tumor, and then we learned that it wasn't the distal margin, but really a total mesorectal excision that would give us a local recurrence rate superior even to chemotherapy and radiotherapy. So when McFarlane from Vancouver looked at Bill Heald's data, he found that the 5% local recurrence rate was far better than the New England Journal article by Crook showing that chemoradiotherapy dropped recurrence rates from 25 to 13.5%, and TME became widely adopted. And we then went on to see that, in fact, we could transmit that education. And so this little study from Sweden showed patients operated on pre-TME who had a 19% recurrence rate, and then after Bill Heald went to Sweden and educated a group of surgeons, the surgeons who picked up the TME technique dropped their local recurrence rate in the next time period to 6%, whereas the surgeons who continued the traditional technique kept up at 19%. Combine all of that together, and can we help patients by adding chemoradiotherapy as well as doing TME? And 1,805 patients in the so-called Dutch TME trial, although that's somewhat of a misnomer because the patients weren't all Dutch, 897, including the short course Swedish radiation, 908 patients surgery alone, and you can see that at 2 years the local recurrence rate was even further improved upon. So TME allowed us to drop these local recurrence rates from 25% down to now 2.4% with short course radiotherapy and surgery in a very well-controlled randomized controlled trial. But that introduced some other problems, which I want to touch on. And one of the other things, when it's what's new in lower GI surgery, well, one of the new things is not just how we take it out, but how we put it back together. And Klaus Matzell from Erlangen showed that the less rectum left behind, the worse the function. So you have these various levels of anastomosis, less than 3 all the way up to greater than 10, and the lower the anastomosis was made, the bigger the problems were with incontinence, with increased stool frequency, with decreased ability to discriminate, and all of the adverse sequelae that go along with it. So, for example, as those levels decreased, stool frequency went from 5.2 a day down to or up to 2.1. The higher the anastomosis, the better the function. Somewhat intuitive. So how do we put patients back together? We know how to take things out, and we've seen this morning that can be done in a very elegant way, whether through one port, multiple ports, robot ports, hand ports, whatever. There are multiple ways to skin a cat, and we know how to take the rectum out. How do we put it back together? The traditional way is a straight anastomosis, but both Lazortz and Roland Park introduced in the same year in France the colonic J pouch, modeled on the ileal J pouch, and then subsequently Kasper Zagagrin from Switzerland brought on the coloplasty. And since that time, there's been a variety of studies looking at methods of reconstruction after appropriate rectal extirpation for cancer. And this one study from Harriet looked at over 2,000 patients comparing straight coloanal colonic J pouch and transverse coloplasty. And of those 3, the colonic J pouch seemed to give the best function, with a statistically significant reduction in stool frequency as compared to straight coloanal, with less fecal urgency, presumably because of a greater, more voluminous neorectal reservoir with better ability to contract. And you can see that up to 2 years after surgery, we still have stool frequency being in favor of construction of a colonic J pouch. Fecal urgency tends to balance out by 2 years. But if you're the patient, even if it's 12 or 18 months of urgency, you'd rather obviously not have that. So the issue is you've got to do something other than a straight anastomosis. This is one recent study randomizing coloplasty and colonic J-pouch as methods of reconstruction. And you can see the Achilles heel of the coloplasty is a leak, which usually occurs anterior at the coloplasty suture line or a dehiscence of the anterior wall between the distal staple line at the anastomosis or distal hand sutured line at the anastomosis and the coloplasty site itself. So overall, the coloplasty did not really hold up the test of time in terms of safety, and more recently, Fazio published a multi-center, multinational study looking at coloplasty versus colonic J-pouch, and the conclusion in the hands of someone who was a champion of the coloplasty, the Zagagran technique, was that the colonic J-pouch was functionally superior to the coloplasty and was recommended for all patients in whom a coloanal is required. If the patient couldn't have a pouch because of a very bulky mesentery or a very narrow pelvis, presumably at that point you could think about a coloplasty, although the end-to-side anastomosis is rapidly emerging as the substitute. Now, this is a difference from Japan, where patients tend to have a very redundant left colon, which is much more distensible and much more compliant, and a straight coloanal will give different functional results in Japan than in the West, and this is something that we need to highlight. Having said that, as we export more of our bad habits to Japan, like McDonald's and Kentucky Fried Chicken, and there's more diverticular disease on the left, this paradigm may well change. But going as opposed to across the Pacific, if we cross the Atlantic, the UK Association of Coloproctology has endorsed a colonic J-pouch after any anterior resection. The other issue, which is often the great white elephant in the room, is who should do the surgery? I mean, we know what's new is definitely how to do it. Robots, hand ports, single ports, multiple ports, whatever. But we also have to think about who's doing it. And there's an increasing number of studies in the literature. You can see some of them quite large, like the Callahan study from New York with 48,000 patients included in that study, or 5,700 patients from the state of Maryland, or more recently the UK study of 8,200 patients, showing that these operations for rectal cancer should be done in high-volume specialist centers, both by surgeons who have trained in colorectal surgery and surgeons who have interest and therefore high volume. And you can see decreases in morbidity through these studies, decreases in mortality through these studies, and decrease in local recurrence rate. How it's done, again, that's what we're discussing this morning, and it could be laparoscopic, it could be open. There's a number of studies suggesting that laparoscopy may well have benefit, and we can debate which type of laparoscopy at the panel, if we're going to have a panel. But looking at Mario Marino's study, for example, from Torino, Italy, the obvious short-term benefits of laparoscopy, but also in intimation, as we saw in Antonio Lacey's trial, of colon cancer, an intimation that for rectal cancer we may actually get somewhat better results with lower local recurrence with laparoscopic surgery. And there's been a couple of different meta-analyses and literature reviews looking at this issue, 48 studies in this one particular Cochrane database, and as we all know, based on the evidence, there are short-term advantages which are objective and clearly measurable using metrics with which we're all familiar, but we don't really know yet the long-term oncologic outcome. We will soon have it. And the COLOR 2 trial has enrolled over 700 patients with the 2-to-1 randomization. You can see here 487 laparoscopic, 252 open. It includes 27 different centers in 6 countries, and the preliminary results have just shown that the stratification in the 2-to-1 randomization schema worked well with well-stratified patients between the two groups. And in this country, of course, we're doing the COST 2 trial with a 1-to-1 randomization and also have very good well-matched groups. And then lastly, the other white elephant in the room is what do you do when the patient's had a complete response? I think this is also something new in lower GI surgery. The idea that you might take a patient with a distal rectal cancer who's obtained a complete response to chemoradiotherapy, to neoadjuvant therapy, and not operate upon them. I mean, this would be considered in some quarters heresy. But yet, there are quite laudable results, notably from Angelita Habrigama in Sao Paulo, Brazil. So 265 patients with distal rectal cancer considered resectable, neoadjuvant therapy given. You can see the responses at a follow-up of up to 57 months. And you can see in the overall survival in the observation group, 100%, and the 5-year disease-free survival, 92%. And this is very new. This is something we all need to be aware of, because we all see patients who say, you know, I had a complete response. Why do you want to take it out? I'm very happy that you have a robot, but I'd rather you don't use it on me. Maybe I don't want surgery at all. What are you going to do? Are you going to observe the patient? Is that safe? Well, Angelita says it is, that if you can get to a stage 0 after neoadjuvant therapy, that you don't need to use the hand port, the single port, multiple ports. You can keep them all in the closet and watch the patient. And I think this is something that clearly needs a lot more discussion and a lot more analysis before we can reach a conclusion. So hopefully I've shown you that besides for laparoscopy, there's a couple of other things that are new with rectal cancer, all of which are going to cause us to scratch our heads and debate a lot here today and in the near future. Thank you.